We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
Yeah, on behalf of IAP Navi Mumbai and MJ Medical College Navi Mumbai, we welcome you all for one more midweek academic box office session. Friends, we know that in this world, the labor pain is the worst pain. And if you ask mother what relieves you from that pain is the first cry of the baby. What is most rewarding for an obstetrician in the labor room is again the first cry. And what keeps the adrenaline level of a neonatologist high till the baby have its first cry. So friends, today's session is about what if a baby don't cry. So I request Dr. Jitendra Gawane, IAP President Navi Mumbai, to carry over the session. Welcome you, sir.
Thank you, Vikram. On behalf of IAP Navi Mumbai and MGM IHS Department of Pediatrics, I welcome you all for this CME on neonatal resuscitation program. Friends, this is a NRP is a evidence-based approach to a care of the newborn at birth and facilitates effective team-based care for the healthcare worker who care for the newborn at the time of delivery, so that best outcome is achieved at the end of the providing resuscitation. So this, as we say, it's a structured program, but over a period of time, as we know, constant thing in the world is a change. So it keeps on changing the guidelines, and we have to be very updated ourselves regarding this. So many changes have happened over last many years, and we cannot carry our what we learned in our MD days. Same thing we cannot carry. So to discuss in this regard, we planned this CME with our esteemed speaker, Dr. Omprakash Jamadar. To moderate this session, we have Dr. Shantala Murthy, who is a consultant neonatologist and pediatrician. She is a calm, composed, and hard-working personality, and that is what is required in labor room when you are attending the delivery. So I request Dr. Shantala to carry on the proceedings.
Thank you, Jitendra. Good evening, friends. I'm Dr. Shantala here. Thank you all for joining in this evening. At the outset, I would like to thank Dr. Jitendra and the entire Navi Mumbai IAP team that is behind this webinar for giving me this opportunity. Today, as Jitendra rightly said, we are discussing NRP from evidence to practice. Many of us will remember the good old movies wherein a white coat doctor would hold the baby upside down, give a few whacks, and lo and behold, the baby cries. Luckily for us, we have come a long way from there. NRP has moved from expert opinion to evidence based. So over the years, many of us have to unlearn what we have learned so that we could learn it the right way, and this would become this would help take rapid decisive actions at the time of need. To elaborate on these current practices, we have Dr. Omprakash Jamadar, who is a neonatologist at Apollo Hospitals, Navi, Mumbai. He has done his neonatology training from Glasgow, United Kingdom. He is a national trainer for NRP and NEST, which he will elaborate during his talk. He's also very spiritually evolved from a very young age. He's young himself, but from an earlier age itself, and is well versed in the Bhagavad Gita. So, Om Prakash, I'll hold you to that so that I can learn this as well from you one of these days. Now, before I hand it over to Dr. Jamadar, please, friends, let's make it interactive session like he has conceptualized. Let's make it a success. Please be liberal with your answers, your queries in the chat box, and we'll try to get to it as much as we can. I now request Dr. Om Prakash Jamadar to take over the session, please.
Thank you, team Navi Mumbai IAP, Dr. Jitendra Gawani, Dr. Vikram Patra, Dr. Mangai, and all the team members. So, Navi Mumbai IAP is, I feel it's a homely affair. So, when I talk with Dr. Jitendra, I felt like, let's sit down together and discuss out all these points about the practices that we do and what is the evidence about the practices. However, Corona has distantly separated us, but no doubt we are together on the screen. So, I will be focusing more on the practical implementations of what we are doing in our implementation of what we have learned in the past and what we are doing right and what we are doing wrong. Okay. So I'll be trying to focus more as much as possible with some examples that we can see in our day-to-day life. So this I wanted to do more of interactive sessions, but with again limitations of this, I will try to post the questions. For those who can answer it, we can post the answers on the chat box in the YouTube. So that will be so that we can review and then we can interpret what we are doing in our practice. So I hope my screen is visible to all.
Yeah. Go ahead.
So there is no any sponsorship for this presentation. Whatever images I'm going to use, they are just for the purpose of representation. This is the place where I've been trained during my earlier days of graduation. And this is the place where I work in UK. And this is the place where I'm working at present. So the agenda of the talk is huge, So NRP covering in half hour or 45 minutes is a difficult task for anyone. In fact, it's a 2 days program. But I will try to cover the most important part, like what is the evidence behind the practices, what are the changes that has happened in the newer NRP. I'm going to add particular aspect of simulation and the behavioral skill, and I want to get views of all the participants about what they are doing at the time of resuscitation of the baby, and there will be a take-home message at the end. So a brief history. Now, Dr. William Kian, many of us must have heard his name. So this is the personality who has done extensive work as far as the promotion of the NRP services are concerned all over the world. From 1965-70, when first neonatology was conceptualized, he has worked on from that age, and I have seen him in all the conferences of IAP. I had got the fortune to meet him when I was there as one of the trainers for the TOT for the trainers. So this was just a good memory for me also to meet him and then interact with him, what the NRP, what he's looking for in the NRP. So evidence-based practices. So when we say EBM, evidence-based medicine, there is something called as eminence-based medicine also, where the people try to pressurize things at the level of evidence, and Corona has given some bad ideas and concepts also how things are changing in terms of the evidence-based medicine. But when I say evidence-based medicine, generally what we remember is this Cochrane, isn't it? And I'm very glad to share with you that this logo of Cochrane is delivered by the gynecologist. So you can see this. This is about the use of antenatal steroids, which was first tried on 1972, and it came into implementation somewhere around 1990. So the evidence is there from 1970, but to come it into practices, it takes long time. This is a very classical example of how practices and evidence there is a vast gap, and how we can fulfill the gap by reviewing the evidence regularly. That is the reason we have got this meta-analysis. This diagram, if you see, there's a meta-analysis about the antenatal steroids, and that shows, the diamond shows that there is a good effect of antenatal steroids in terms of the survival of the baby, the maturity of the lungs, and prevention of ROP, and all the other benefits that we are familiar of. So evidence-based medicine is basically is a based research available, and we look particularly at the randomized controlled trials, double-blinded in that particular. Then we take into consideration the patient values and clinical expertise. So clinical expertise can't be completed, that we can't skip. Nowadays there are so many online courses are there, but I remember a quote which was written in front of our lab in KM hospital, that until and unless you sail in the sea, don't expect that you will be able to bear the winds, the heavy winds that you face in the sea. So similarly, until and unless we have got the clinical expertise, bedside expertise, just the evidence-based medicine is not going to help us. So we need a clinical practices at the same time. So NRP has got an evidence base. So every 5 years, the LCOR reassess the evidence. And in fact, I will say before 5 years also, they do give recommendations. In particular, if there is any new additional finding they have noted in shorter than 5 years time, they do amendments regularly on that. So last time NRP what we got updated was in 2015, and then there was a 7th edition of NRP in 16. And from that time also there are some few additions are there. So if you know background like of NRP, we see birth asphyxia in almost 1/4 of the new, contributing for 1/4 of the neonatal deaths. And this is not just the Indian scenario, this is world war scenario. And 90% of the babies don't require any significant support at the time of birth. 10% requires some kind of support, and only 1% requires extensive resuscitation. But the trick is we don't know who is in that 1%, and that is the reason we have got the antenatal history taking component, which was added in the newer guidelines of the NRP. Now, this is the inverse pyramid, again implicating the same, that very rarely we need chest compressions, medications, but most of the time we just need the supportive care in terms of the positioning, clearing, and drying the baby. So these are the 2010 guidelines. So here it is starting directly with the question, whether it is a term or term gestation, baby is breathing or crying, whether the tone is good, and then is progressing further in terms of the assessment of the heart rate, assessment of the respiration, and then accordingly we decide about giving the positive pressure ventilation. I will be discussing more on the next chart, which is the recent one. So 2015, this is the newer version of that. Now, the difference in the diagram I will discuss further. So in the previous diagram, you can see there are all squares, but here there are squares, and there is a different colors of the squares, and there is a different shapes. Diamonds are also there along with the squares. So squares are basically what you are going to perform, and diamonds are assessments. So that is one way. So these are called as visual aids, that I'm going to discuss further when I'm talking about the next subsequent slides. So the first and foremost thing what is added here is the antenatal counseling, team briefing, and equipment check. So I always ask whenever I'm doing any sessions on NRP, I tell them 3 checks. So check your environment, check your equipment, and check the persons available to help you. After that, is the birth of the baby, and at the time of birth, we assess 3 things: term, tone, breathing, or crying. Now, if you see the questions, they are very precise questions. They don't say, is it a term baby? No. Is the good tone? No. They say only one word. Why we are very precise? Because it is a time frame, time limited action that we are going to do. Term, tone, breathing, or crying. So the answer to this will be yes or no. And based on that, we have got the action to be done. If everything is fine, the answer is yes, then baby goes to the mother's side. However, if there is any answer which is no, then we are going to receive the baby in a pre-warm towel. We are going to position the baby properly. We are going to clear the secretions if there are any. We are going to dry and stimulate and then reposition the baby. After this, We are going to assess whether baby is breathing, particularly look at the apneas like cessation of the respiration, or if it is a gasping respiration and heart rate is less than 100 or not. Again, the answer will be yes or no. If answer is no, however, baby's breathing is labored or there is persistent cyanosis, that means there is a need of some support. So we make sure that baby's head is in head neutral position. If there are secretions, we clear the airways. We are going to add the monitor, the SpO2 monitor, and as per the requirement, consider giving oxygen or CPAP, particularly if the baby is having some grunting or distress. Now, this is only for the labor breathing. However, if the baby is having apnea, gasping respiration, or heart rate is less than 100, that means baby needs support, and that is in terms of the positive pressure ventilation. Now, whenever there is a need of positive pressure ventilation, we need to make sure that the pulse ox monitor is attached to the baby. And I always say right is right. So, what is that? So pulse ox has to be attached on the right hand of the baby, never on the other side, so that we can get a better values of the pre-ductal saturation. Okay. And then ECG monitor. I'm going to discuss a bit more about this saturation monitoring and heart rate monitoring in the next subsequent slides that I'm going to have. Now we are up to positive pressure ventilation. Now, once we start positive pressure ventilation, we need to make sure that the positive pressure ventilation is effective. And what is the best way of assessing that? One is clinically you see the rise in the chest. That is one part. And second, once there is an effective positive pressure ventilation, you see improvement in the heart rate. Now, color was there in the previous observations, but in the new NRP, we don't look at the color of the baby. Particularly, extremities take longer time. Sometimes, at the time of 10 minutes also, we give 9 Apgar score because the extremities take longer time to get pink. So color is not there. It is more of the saturation of the baby, the pulse ox that is going to guide for that, and the heart rate, which can be by manual examination or by ECG. So heart rate and saturations are improving. That means your positive pressure ventilation is effective. If there is no effective chest rise, what we are going to do, that again I'm going to discuss further. And after the corrective step, still you are not able to do the proper chest rise with positive pressure ventilation, we need to think of either laryngeal mask airways or intubation for the baby. Now, the heart rate, I have said one is 100. Now, second heart rate, what we remember is 60. So these are the two values which we should try to remember. Heart rate less than 100, we are going to think about positive pressure ventilation. And if there is a response to positive pressure ventilation, the heart rate increases more than 100. However, if there is no response, it is a secondary apnea. So it is not going to respond very quickly. The heart rate may drop further. So in that situation, we have to think of intubation. So intubation, so there are two situations where we need to think about intubation. One, you have tried for ventilation corrective steps, still things are not getting better. Then better to think of earlier intubation. And when there is a need of intubation, we need to make sure we are starting with proper oxygen, somewhere around 50 to 60% oxygen. Okay, that is one thing. Second, if on assessment heart rate is persistently less than 100, that is further dropping to less than 60, we need to think of chest compression. And it is safer and better to do intubation before we go for chest compression, because coordination as well as the effectiveness of ventilation is better with bag and tube ventilation than bag and mask ventilation when there is a need of chest compression. Okay, so ongoing saturation monitoring is very important. And if still there is no improvement in the heart rate in spite of the effective positive pressure ventilation, you are given 100% FiO2, then we go for the medicines. And the medicines what we use is epinephrine, normal saline, and in rare situation, ORH negative blood. Okay, particularly if we know there is a significant fetal or antenatal blood loss is there in that situation. There is another square that has been added very specifically to make sure that the saturations takes almost 10 minutes to reach in the range of 85 to 95%. So many times earlier also we used to feel, bag and mask ventilation we are giving without oxygen, that means we are not doing right. But here if you see, it takes almost 10 minutes for the baby to go for saturation of 85 to 95%. So we have to start with room air ventilation and not with oxygen at first instance. So now, what are the practices which we have changed? I talked briefly just in the algorithm, but there's a lot of focus in this newer editions of NRP about the team preparation and role assignment. Then second is anticipation of delivery. Counseling is another important aspect has been added. And third is who is attending the delivery. Now we need to make sure at least one trained person is there to attend the delivery at all the given situations. Now, many times we may not have got a fortune to have more than one person, but here it has been very specifically said that at least one trained person should be there when the delivery is happening and who has been trained for giving positive pressure ventilation. Now, teamwork is very important. Team, I sometimes say, together efforts achieve more. So I'm going to share a video of this. Hopefully, it should play well. So I think I'm going to minimize it and then. So this is a video about how the team efforts makes so much of difference. The actions, I want all of you to time up the actions, what they are doing and how they are doing.
Omprakash, your video is not being shared.
I'm sharing my screen now.
Yeah, share screen and then you start the video.
Is my, I hope my screen is visible now.
Yeah.
Is the screen visible to all?
Yeah, the screen is visible.
Yeah. So I'm going
The
to
video,
play
you
the
want to
video.
play it from the beginning? Yeah.
Yeah, I'm going to play the video again. So you can time up in how much time, what activities are happening in this video. So if you have time for this video, in fraction of seconds, so they have changed all the wheels, they have filled the petrol, they have done the engine work also for this. And this is possible because you can see the number of people involved in this team. So they are in coordination. Everyone is doing their own job. No one is saying like you do this and I'll do this. They are very focused in their activities. And then within fraction of second, if you put your vehicle into garage, it may takes days to repair it. I've got this difficulty since lockdown time, almost since like 3 months my vehicle is in the garage. But here, within fraction of seconds, they have repaired the vehicle and then it has gone. Why it is possible? Because of the team efforts. So similarly, when we are at bedside at the time of resuscitation, we need to make sure that we are doing the activities in a team manner. So we are going back to the presentation now again. So how many of you remember when you joined your post-graduation or maybe some new students comes to your institute for training? Do you remember what has happened, how things were? So we were pushed to attend the calls without knowing anything, ABCDs, and what to do, what to ask. So it was like jump in water and you learn swimming. So something like this, if you hold the four wheel and make the rubber meet the road, that is what we have been doing in our training. So I remember still when I was in UK for initial 2 months, they just observed me. They made sure that I redo their NRP, get a certification before I start working. So same thing what I try to do implementation in our practices at Apollo also. I make sure that we train the residents before we make them work. So this is a good evidence that tells us that training about in newborn resuscitation decreases the neonatal death in first 7 days after birth. And all of us know the ground force, the residents, they are there at the time of emergencies. We consultants many times may not be immediately accessible because emergencies come without knocking the doors. So in that situation, we need to make sure that they are trained for handling the baseline emergencies before they are pushed to the scenario. That comes the rules of simulation. So before we make them work, we need to create an environment artificially to give or mimic processes or conditions that cannot or should not be experienced first time by a student because of the student's inexperience or risk to the patient. Now, someone who is not aware, like for decreasing oxygen, you need to give certain amount of oxygen. It is risky for them as well as risky for the patient. So there comes the role of simulation techniques. So there are different definitions of simulation. So one of them is to replace or amplify real experiences with guided expertise. So simulation is a very controlled environment where we know what difficulties they are facing, what are the things that they need to improve, and what they are doing rightly. So that gives a lot of confidence to the person who is doing the simulation and the real life experience that they go further. And another one, what I got is it is a generic term that refers to artificial representation of real world process to achieve the educational goal via experiential learning. So whatever aims that the students have during their first 6 month or subsequent second year and third year, that can be set forward in the simulation, and then we can assess them by simulation. And believe me, with this COVID times, simulation is going to be one of the ways of assessment. By preventing the close contacts, the examiners may sit at a long distance and on a video consultation or something like that, they are going to assess you. So we need to work a lot on this simulation. And this is, there was a recent seminar on BC and DC. So this is before COVID simulation that we did in Apollo Hospital. And this is during COVID. Now, one of the DNB resident joined with us recently. So I again make sure that at least they do understand the basics of the NRP in terms of the effective positive pressure ventilation. That is the key step I always say. So now 10 key behavioral skills that are being focused a lot in NRP. So first is know your environment, the place where we are going to rescue the baby, where you are going to resuscitate the baby in case of need. You should know how is the environment, and very important to make sure that the temperature of the environment is taken care of. The second is anticipation and plan. So until and unless you understand that we don't know that 1% of the situations where the baby may require all sort of help, so better we prepare. However, in a situation where we already know that it is a preterm baby, it is an IUGR baby, again the chances of having difficulties is on a higher side. So in that situation, we should make sure that there are extra pairs of hands are available to help you. Assuming the leadership role, this is very important. A leader is someone who is actively doing things and at the same time keeping a eagle's eye on everyone what who is doing. That is one way of leader. Second is a leader who is not actively doing any action activities, but inactively making sure that everything is in place. So both these parts are very important. And sometimes leaders do mistakes. In a situation of crisis, if you are not quiet and calm, as Dr. Jitendra already said, the leader can do blunders if the focus is not there, if they are diverted by something else. So in that situation, there is an important role of the team members to help the leader. So it is not a shortcoming of the leader, but it is the crisis that creates this scenario, and the team has to manage the crisis. Now, communicate effectively is very important. The closed loop communication is everyone is familiar about whenever we are talking about the NRP. Delegate workload optimally. Now, optimal is again a very important thing. Look at the abilities and capabilities of the person. You confirm whenever you are saying like you are going to help me for bag and mask ventilation. Are you okay with that? You confirm with them. Are you okay with the chest compression? You confirm with them. If they are saying yes, I can help you out, I can do chest compression, I can do bagging, then only give the role to them. Otherwise, it is not very safe practice to give someone to do things which they are not very much confident of. Allocate attention wisely. That is another important aspect of a leader, that he should decide the priorities, what to be done. Now, sometimes, if we ask one person to get things, everyone runs for the same. So the leader has to guide very precisely by communicating very precisely that, Mr. This, can you help me with the pulse oximeter? So that only that person goes and takes the pulse ox and attaches the pulse ox. That is very important. Use all the available information, all the available resources appropriately, and call for help is one aspect which many times we feel, I'm calling for help, that means I'm not capable of doing things. It is not like that. See, certain situations are beyond our limits, where we need extra pair of hands. As I showed you in the Ferrari video, where there are 8 people working unanimously, and within fraction of second the job is done. It is not that every one of them is not compatible of doing the other work. They are compatible, but we should know that if things has to be done within the first golden minute, we should know what are our limitations and when to call for help. And the crux of all this is maintaining professional behavior. Again, this I insist a lot in our Indian scenario, because many times when we are in a crisis situation, things are going haywire. We start shouting people, we start yelling people, we start blaming people. That should never happen. That is the reason we should have a briefing at the end of all sessions. So even in our NICU, what we practice, like, after doing this major resuscitation, we sit down with our sisters who were involved. We sit down with the residents and make sure that what are their feedbacks, and then accordingly try to improve in the next situation. So this is how it should be. We should try to get the positives from them, and then you should try to put them in the same scenario and ask them back, like, what you will do differently next time. It is a guided experience that we have to give them, and not a spoon feeding at this stage of their life. So it is very important to stimulate and then get the answers from their own mouth. That is very important. Again and again I'm saying, because until and unless it comes from their end, they are not going to follow next time. If you tell, they may do for some time in front of you in particular, but in your absence they will do the same mistakes again and again. So we need to make sure that we have to maintain a professional behavior and do the debriefing of the event, whatever has happened, so that the same mistakes are not happening. Now, behavior skills. So this is another beautiful video that I'm going to share with you. Let me see how it works. So behavior skills, I already talked about having a professional behavior. That is one aspect of it. And then communication with each other, communication with the relatives of the patient. That is another area where we tend to be busy with the baby, and we forget the mother who is there beside the baby and who is looking anxiously, like, what is happening to my baby? I want to know. So I always suggest one of the team member, particularly the team leader, should go back and inform to the mother that this is the present situation of the baby. I'm going to talk with you in detail once we stabilize everything, but we are trying to help out the baby. This gives a lot of solace to mother. So make sure that communication with each other and communication with the parents is equally important. Then and then only it will be a successful event of a resuscitation. So this is the next video I wanted to share with you. So let's see how it, yeah. So this is a very interesting video where
dad to 2 young children, Victoria and Adam,
he's saying he's dad of two kids.
the death of my wife.
Is the voice audible?
No, the voice is not clear, Omprakash.
Okay, so voice is not very clear, I think. So I'm just telling you simultaneously. So his wife went for an elective surgery and everything was fine. Pre-anesthesia checkup and everything was done. However, before they start the procedure, the oxygen saturation started dropping. The anesthetist, you can see, they are trying by giving oxygen. There were 3 consultants who are working by different ways. They are trying to do the video laryngoscopy and intubation now. So this was a situation of can't intubate. They are struggling for intubation, and it took almost like 10 minutes for them to do all this activity, and everyone was just very anxious what to do. They were trying to bag, but the saturation was not improving much. So you can see all the consultants there working hard for maintaining the saturation.
Surgeon has over 30 years experience.
So the surgeon was 30 years experienced personality. He is very expert in managing the difficult airways, but still he was not able to manage this particular situation.
At this stage, what was going through their mind?
So you can see the saturations.
Attempts had failed. The oxygenation was very low.
It is dropping up to 50s.
What actually happened is this point in 10 minutes for a further 15 minutes.
So 10 minutes are already passed, and again for 15 minutes they are again trying for repeated efforts of intubation by 3 different surgeons and anesthetists.
They eventually get Elaine's oxygenation to 90%, but she's actually been at 40% or lower for a total now of over 20 minutes.
So for 20 minutes the patient was on a saturation of 40 to 50%. So they are discussing with each other.
Is not secure though, and so they fiddle around a bit more, and in fact oxygenation falls again below 90% for a further 10 minutes. And finally, by the time we're 35 minutes in, they seem to make the decision that the best thing is just to let her wake up naturally.
And at the end of 30 minutes they said, like, just go back to the ward again. Now you must have seen the sisters were also around there. They were observing here and there.
She lays there for an hour and a half. Of course, she never wakes up.
And afterwards, she never woke up, and she died.
Based on the evidence from the inquest and from Professor Harmer's report, the lead anaesthetist, if I can call him that, in his own words, lost control.
So there's a lot of analysis of this event happened in NHS, and it was a reform of crisis management, what they are doing.
An awareness of time, but also an awareness of the seriousness of the situation. If you like, the awareness of what was happening wasn't shared by each of the consultants.
So there was lack of time management. There was focus which was not given at right places, and options what are available they are also not thought of.
The story with the nurses is very different.
Now if you see, the nurses are there. Now this one of the nurse we saw earlier also. Now, they were struggling for the airways. They are trying different ways and maneuvers. Now this one nurse, she goes outside. By the time they are trying with the video laryngoscope, look at the airways, she comes with this tray, and so this is a tracheostomy set she got. She looked towards the doctors, but there was no response from their end. So she didn't spoke, she just came, She tried to call some other people.
Bed was immediately available. She came back in.
She called to another doctor.
Bed was available in intensive care.
So you can see the junior nurse who is standing with that tracheostomy tray, and another nurse went and then called for some other help. Call for help has happened there.
You overreacted. She actually walked out and cancelled that bed. At the inquest, two of the four nurses.
So there was an inquest which happened for all this, what has happened, why it has happened.
But again, to quote from the inquest, didn't know how to broach the subject.
So this is a real life example of how things have gone wrong at a routine surgical procedure.
Story of the death of my wife, Elaine, who died in March 2005 as a result of attempted routine operation that went wrong. There's some confusion about the precise time, but we know that 6 to 8 minutes in a number of things were happening. The anaesthetist had already started to attempt to intubate Elaine. The oxygenation was still at 40% or lower, the heart rate was falling. The ENT surgeon waiting to perform the op came into the theatre. An anaesthetist from an adjoining theatre became aware of a commotion, and he walked in to see what could be done. And at least 3 nurses answered a call.
So back to the presentation again. So we can see how communication is important. When you are fixed at one aspect, we need to make sure that others are helping you out to sort out the difficulties that you are facing. But here, everyone was facing at one aspect of it, that is how to improve the saturation. But they were not looking for the other ways of helping to improve the saturation. They were just trying with bag and mask, the self-inflating bag they were trying, and then they were trying with a normal laryngoscope and video laryngoscope. However, no one was looking at the nurse, and neither the nurse commented in between that there's some other ways of doing ventilation by doing an emergency tracheostomy. Now, many situations where after anesthesia check and everything, there are difficult airways that we also face in pediatric practices, in adult practices. So we need to think of other options available, maybe a laryngeal mask airway or a tracheostomy. Now, this is how a just routine operation. He has lost his wife and he has got 2 kids. And when he was asked about his feedback, like what he will do now, so he said he won't blame the doctors. He said that I want to make sure that this thing doesn't happen to others. And from there, the timely management of situation has been focused a lot. The crisis resource management, he himself is from the airline services, so they have been trained about CRM principles. So they started coming in picture with the medical practices, and the simulation has also played a vital role in training the people to make sure that things are in place in case of emergencies. Now, allocating attention wisely, this is another video which I want to share with you. So in our practices also, what happens when we are doing a chest compression or when we are doing a positive pressure ventilation, we have to keep attention on the chest rise and keep attention on the responsiveness in terms of the rise in the heart rate and saturation. However, sometimes people are focused on only one aspect of it, and then as a result, babies not maintaining saturation, there is no effective chest rise, and then you are just looking at something else. Maybe like someone is struggling for the cannulation, and then you are just trying to say them like, put umbilical line this way, that way. So this is another video which I want to share. Is the video visible?
No,
Yeah. Now the video is visible. So you can see the instructions. Count how many times the players wearing white pass the basketball. So our attention is very important in this video. How many times has someone counted it, hopefully? So there are 15.
Yes, I saw the gorilla.
Isn't it? So that means Dr. Jitendra's attention is quite good. So this is also one of the way that help us practices that our attention needs to be wisely diverted at all the places whenever we are in the situation of crisis. So going back to the presentations. So back to
I guess Sweekar also got it right. So good
very
attention.
good. That's very
No,
nice.
actually, I was not counting the passes. I was.
You were only looking at the
That
gorilla.
is the wrong answer. The question was to count the passes. It is not just looking at the gorilla, isn't it? So if you get the right number of passes, then you will miss the gorilla. That is the trick of this video. But if you're just looking at the gorilla, then that means you are not going to answer the question in the exam.
Exactly.
He has finished all the exams, I guess. So
Yeah.
he's
So we will next move to the next NRP in action. So let's see what we do in delivery room. So attention span is one aspect which I want to talk whenever we are doing any presentations. So to start with, everyone must be straight. By this time, I expect that everyone must be a bit lying down and relaxing. So the attention span, when I was reviewing in the literature, so it is saying that the attention time average is like 10 to 15 minutes. And I have done my job in 10 to 15 minutes of covering the NRP flowchart. That was the primary target. And the second target, I want you to be awake, because here we need to keep your pen and pencil and a paper ready to answer the questions that what we are going to do. So I expect with the help of this audio visual aids, we are going to keep you awake for the rest of the part of the presentation also. So we are going to talk on BC and DC, which is before Corona and during Corona. And I'm going to talk on TC, which is like a ticket checker. I'm going to check our practices, what we are doing, and in the delivery room and in the term of resuscitation of the newborn. So now I want to ask all of you, how many do 3 checks before the birth of the baby? So I told you about 3 C's, like check the environment, equipment, and personal. How many of you do that 3 check? Second question I want to ask, do you have the checklist of things which are required at the time of resuscitation? And third is, do you have the NRP algorithm attached to your resuscitation trolley or on the wall where the resuscitation is happening? Now, some of you can reply directly, and our moderators are keeping a close watch on the answers so that we can get an average percentage how many people are doing what. And some of you who are on the YouTube, you can message on the YouTube also. So checklists are one of the visual aids. I don't say specs as only visual aids. That helps to prevent us doing mistakes. So checklist at the resuscitation trolley help us to make sure that everything is in place. That is one. Second is algorithm also make sure that by mistake, if you are missing some steps or if the baby's response is not there, again, you should go back to the previous step. Like if you are doing a positive pressure ventilation, not happening well, you need to go back to the corrective measures again and again, and still not happening, they need to think of going for the intubation. Because in case of crisis, sometimes not everyone is quiet and calm. People get so panicky, it feels that that person need resuscitation than the baby requiring resuscitation. So all the checklists and algorithms help us to make sure that things are in place before the resuscitation process is started. Now, second question I want to ask all of you, where do you deliver a baby who is breathing and crying? Do you receive the baby in a tray and ship to warmer, or you deliver the baby in mother's abdomen? If I ask the questions, many of will say mother's abdomen, but are we really doing it? That question I want you to ask to yourself, and you can answer, and then accordingly, we know the importance of delivering the baby on mother's abdomen. The first and foremost thing is giving the warmth of the skin of the mother. Then KMC, we are talking a lot in the preterm baby. So that process has started skin to skin contact at the time of birth itself. And automatically that helps to do the hormonal changes in the mother's early production of the milk. early contraction of the uterus once the baby starts latching and the breastfeeding also. So temperature is another aspect of that, which makes sure that when baby is in touch with the direct mother skin, the temperature of the baby is also very well maintained. So any baby who is breathing and crying, not requiring any support, we should make sure that we are delivering that baby on the mother's abdomen. Now this requires a lot of cooperation and coordination with the gynecologist. The second thing which we need to focus in coordination with the gynecologist is the cord clamping. So how many of you do cord clamping immediately, less than 30 seconds, or after 60 seconds, or during 30 to 60 seconds of birth? Now, some of you can answer the questions while we are talking. So, delayed cord clamping has got a proven evidence that it helps a lot for improving the outcome in terms of morbidities and mortalities. So, this is a systematic review which has proved that it is delayed clamping without cord milking for 30 to 60 seconds versus immediate cord clamping. It has helped to decrease the mortality by 32%. Now, 32% is a very significant number, and this is just by one intervention of delayed cord clamping. And this is the meta-analysis. Again, we can see very clearly the diamond is on the left side, which favors the delayed cord clamping. Now, how much is the delayed cord clamping? That is another question that many of us must be thinking. So, what the guidelines suggest, 30 to 60 seconds.
Sorry, may I interrupt, Dr. Omprakash?
Yes.
You're not sharing your slide. Is that okay, or do you want to share your slide?
Are the slides not visible? Just one second.
No. Four doctors have replied that they cord clamp in 30 to 60 seconds. 5, I guess.
So I just don't want the answers to be right. I want the practices to be right. See, that is the purpose of our today's presentation. Not just the MCQ based question and answers like you know the answer, you are good. It's not like that. But how you are implementing in your practices, that is my only aim of today's presentation. So now one, I told that I hope the screen is visible now. So one, I said that it decreases the mortality by 32%. In addition to that, it helps to decrease the number of transfusions, particularly for the preterm babies. However, there is increased incidence of polycythemia and jaundice. But these are all very minor in comparison to the benefits that we have got. There are many difficulties in terms of explaining it to the gynecologist to convince them that delayed cord clamping has to be done, and the pediatricians sometimes find it difficult. So if you tell them that there is a 32% increase in the survival of the babies, no gynecologist will say no to the delayed cord clamping. So a lot of misconceptions that it causes increases the maternal hemorrhage or mother requiring blood transfusion. So all these are not very significant events like low Apgars, baby requires likely possibility of baby requiring resuscitation if you are doing delayed cord clamping, baby is having temperature issue, IVH, NECs, chronic lung disease, development of ROP. So all these things are not noted to be significant for babies and who have got like delayed cord clamping at the time of birth. One thing I would like to mention, there's a difference between delayed cord clamping and cord milking. So when you are milking the cord, you are gushing the blood in the systemic circulation for the baby, that increases the chances of intraventricular hemorrhage. However, when you are doing delayed cord clamping, you are naturally allowing the blood to flow from the placenta to the from placenta to the baby. So there's a difference. So I won't recommend, in fact, the NRP won't recommend the milking of the cord. They recommend only delayed cord clamping with natural flow of blood from placenta to the baby. So this is the consensus summary of the review, which tells that it is quite helpful. So make sure that we are practicing delayed cord clamping in our day-to-day practices. Now, next is thermoregulation has been focused a lot in this version of NRP. So how are you doing thermoregulation in your practices? That is the next question I want to put forward, in particular for the preterm babies. I'm going to give a hint for all of you. So the 2016 we are not going to forget, and 2018 something happened which may give us a clue, and I'm sure 2020 no one is going to forget. So plastic wrap or bag versus routine care. So babies who have been covered, particularly babies who are preterm, extremely preterm, less than 30 weeks, if you receive them in a plastic wrap and then cover them in the plastic wrap and keep under the warmer, that itself creates a micro environment where the humidity is maintained. It's like a mini incubator that we are creating for the baby. So this is very helpful. Again, you can see the diamond is on the left side that tells that decreases the hypothermia on admission of NICU. And I must tell you that hypothermia and mortality of the baby, there is a direct proportion. The lesser is the temperature of the baby, the higher is the chances of mortality and morbidity. And even 1 degree Celsius different than the expected temperature range causes a lot of difficulties for these babies. I remember during our KM days, babies used to come from all over Mumbai and periphery, and they were like frozen. And these babies, in spite of all efforts, sometimes the metabolic acidosis is so bad, they have got fired of all systems that we can't recover them back to the normal status. So make sure that temperature is very much taken care of at the time of birth of baby, and that starts from the temperature of the environment. So plastic wrap improves the core temperature and it decreases the risk of hypothermia for the baby at the time of admission. So this is how a baby is received in a plastic wrap. And you can see the head is also very important part to be covered because that is like a maximum surface area for the baby. So other ways are warmers, wraps and cap, thermal mattress, warm humidified gases are also very important. Otherwise, they themselves can cause sometimes the dryness of the airways and apneas and stimulation. The dry air itself sometimes stimulate the apnea in the babies. So room temperature is very important, and incubators. This is like a NIC on the wheels where we have a transport incubator with a maintained temperature. Along with that, there's a transport incubator which has got a battery backup, and we can use CPAP as well as ventilation using this. So last week, I think exactly a week prior, we had a session where we talked a lot about walking, running, and exercising. So I'm going to do a task for all of you to hold breathe for 1 minute and then share the time when you lost the breath control, and whatever it may be, 20 seconds, 30 seconds, 40 seconds. Someone is doing more than 1 minute, then that is good. So you can start your time now. So I am timing you on. So everyone is ready. I'll just start the time. Sorry. Yes. So I have done the exercise with moderator already, so we can review the answers simultaneously. I hope people are not turning red and blue.
Omprakash, you better tell the time that it's been. We don't want to give CPR to the rest of them now.
The first golden minute. So it is so difficult to control our breath for a minute. So we can understand the urgency of the situation for the baby in the first golden minute. And this is the time frame where we have to do timed action. So timely interventions makes long-term as well as the immediate outcome in a very beautiful way. So what is the evaluation that we need to do is look at the respiration and heart rate. 3-lead ECG is recommended, and pulse oxygenation is very important when you are doing the assessment. So I'm going to talk with one by one. So heart rate is the first parameter. So this is like a dil ki baat with sabke saath. So how do you assess heart rate? So there are different ways, maybe palpation, auscultation, pulse oximetry and ECG. Now NRP recommends the ECG, but in practices, it is difficult to attach the ECG leads until and unless you are cleaned your chest of the baby. But at the same time, I will say the pickup rate when there is a bradycardia for the baby with ECG is very good. That is the reason, with lot of evidence, NRP has suggested ECG for assessment of the heart rate. So these are different ways where there are ECG monitors are there, capillary capacitive sensors are there, ultrasound is used, pulsation palpation at the level of umbilicus, femorals as well as the brachial pulsations. Now, physical palpation at umbilicus is not a very good idea because you may miss certain beats at the umbilicus, because that is the reason we don't suggest looking at the umbilical pulsations as a standard of practice. Now, if you go one by one, so ECG requires attachment of 3 leads. We can get a continuous monitoring, and it is a gold standard because the median time required to get the values are 1 to 24 seconds. So here we are talking about seconds. We have finished the 30 seconds, and in the next 30 seconds, we need to decide what we need to do. So this will help a lot to pick up the heart rate, particularly when there is a severe bradycardia. Second is pulse oximetry. Most of us have got this. It takes almost like 12 to 60 seconds for the pulse ox to pick up the heart rate. Digital stethoscope, tab-based smartphone applications, Doppler ultrasounds, many times we don't have that. Tab-based smartphone applications are available, which is also good. However, requires auscultation and simultaneous screen tapping. And median acquisition time is 15 seconds. Doppler is another way, but again, it is done more in the research rather than in the real life practices. So there are some photoplethysmography is also available, camera-based photoplethysmography, then capacitive sensors. These are all under evaluation and may not be available and practical for all of us. So what I will take home from this assessment of the heart rate, one way is auscultation. However, when we are doing chest compression, it is difficult to interrupt. You can have a pulse ox that will help you better, and looking at the peripheral pulsations, particularly the femoral and the brachial pulsations. Next, after assessment of the heart rate, we need to think about giving the positive pressure ventilation. So I'm trying to go in the same sequence what we have learned in the flow chart. So how do most of us give positive pressure ventilation? Is it a bag and mask ventilation, TP resistor, or a neoperf? So most of us have got a bag and mask as a mode of giving positive pressure ventilation. So here the difficulty is, it is difficult to give the PEEP with normal bag and mask ventilation. There are certain bag and mask where we can have the PEEP set. Again, which is not very easily available. We have got another session on oxygen, giving oxygen, different ways of giving oxygen. So that is not available for us to easily use. Next is this flow inflating bag. So for us, it is very difficult to give a appropriate chest rise using the flow inflating bag. You need a lot of training as anesthetists, they do use on a routine basis. And then T-piece resuscitator. So this is a very good equipment which we have got an inbuilt resuscitator with a T-piece resuscitator that I have showed in earlier picture also, where we are doing training with a T-piece resuscitator. And then we can have a portable neoperf that also does the same job. So here we can deliver PIP as well as PEEP, and this is a flow driven equipment, doesn't need any electricity supply. Some of these equipments don't have an inbuilt blender, so we are giving like 100% oxygen, but the one which is having in the machine with this inbuilt warmer, which is like called as a resuscitator. So this has got a blended air and oxygen combination, so we know how much percentage of oxygen we are giving to the baby. So delivery room CPAP. Now in Indian scenario, we always feel that we are resource limited Indian settings. But believe me, been working in different places in India, most of the settings are having all essential facilities. What is lacking in government setup is the lack of initiative by different people to use the facilities. So this is a trial. So I thought like I'll put a resource limited setting evidence, which is again done from KM hospital. So they started labor room continuous positive airway pressure for babies who are less than 34 weeks. And very interesting outcome come. There was 36% absolute risk reduction in the need of surfactant and 50%, 56% reduced need of mechanical ventilation in the CPAP group. So these numbers are very significant. 36% decreased need of surfactant. That means you are saving a lot of cost by having a simple equipment of a neopuff or a resuscitator, and you are decreasing the need of mechanical ventilation also. So you may have got a less number of ventilation, but if you have got a delivery room CPAP, you can make magic in these babies who are less than 34 weeks. So we should make sure that we are starting CPAP for the babies who are having grunting distress, who are particularly less than 34 weeks, having labored breathing in the delivery room itself. That makes a lot of difference in terms of the survival as well as the cost effectiveness of the NICU. Now, going further with the positive pressure ventilation. Now, we have started with the positive pressure ventilation, and the best way of effectiveness of positive pressure ventilation is clinically chest rise and associated improvement in the heart rate. However, if there is no improvement, that means there is some difficulty. So this is one of the visual aids where we can use like a MR SUPA. So M is for mask adjustment. R is repositioning of the airway by having a proper head position. S is suction of the mouth and followed by nose. O is opening the mouth slightly and move the jaw forward. And P is increasing the pressures, and A is for alternate airways. Now, if you see this sequence, they are evidence based. So commonest mistake what happens when we are doing positive pressure ventilation is your mask, holding of the mask is not appropriate. So make sure you are holding the mask appropriately. The mask is appropriately sized. It is covering the chin, the mouth, and the nose, not the eyes. Okay. Then second is repositioning of the airway, because when you are handling baby either go into too much of flexion or hyperextension. So we need to make sure that the head is in neutral position so that airways are in line. Third is obstruction of the airways. So by the time you are doing all this maneuver, there may be some secretions that are causing ineffective positive pressure ventilation. So we need to make sure that the airways are clean. Then opening out the mouth, that also many times helps by giving a more positive pressure to the baby. And the subsequent parameter is the pressure. See, the pressure we are increasing at the end because we know the pressures can cause a lot of damage, and there is a direct correlation between the delivery, like the positive pressure ventilation that we are giving, and development of chronic lung disease, the problems of pneumothorax in the term babies, meconium aspiration babies. So we need to make sure, we need to be very careful. That is the reason this new puff help us to set the PIP also, where we know how much pressures we are giving. We are not giving too much of pressures. So when I was doing this demonstration with our residents, they were like, with new puff, they are getting a normal chest rise, but they felt that the chest rise is not enough or adequate. And on the contrary, when they are doing bag and mask ventilation, they felt that the chest rise is adequate. But believe me, the pressure that we are giving by bag and mask ventilation will be too much in comparison to the major pressure that we give by a T-piece resuscitator. Now, supplemental oxygen. I'm sure most of us have got a pulse ox, and many of us have got a pulse ox in our house, whether it is a medico or non-medico. The COVID has got additional advantage of pulse ox in your home to measure the saturations. And many patients call us like, this is my saturation today, like what should I do? And second is, how many use blender? Many of us have heard the name of blender. So supplemental oxygen, as I showed in the NRP chart, it takes 16 minutes for the saturation to improve. Sorry, 60 seconds. So the first 60 seconds, the saturation I remember in 60%. So 10 minutes for the saturation to reach 85 to 95%. So this is again based on the evidence that we have got. So they try to give oxygen 21% and 100%, and then they try to look at the outcome of the babies. So there is higher mortality associated with 100% oxygen. So once we used to say like we need to start oxygen early, without oxygen, if you are doing resuscitation, then it is not effective resuscitation. But now we are on the other side of the game, where we are saying that oxygen is a medicine. If you are giving too much of oxygen, then it creates the free radicals, and the free radicals itself causes lung injury, They have a contribution on development of chronic lung disease, on the development of pulmonary hypertension. So we have to use oxygen as a medicine. So start with 21% oxygen for a term baby, and babies who are less than 35 weeks may require 21 to 30% oxygen, and then look at the saturations, what they are, and then accordingly timeline the saturations. In first 1 minute, I say like 60 second saturation is 60, and then subsequently every minute you add on 5, like 60 seconds 60, then 2 minutes 65. In this way, it takes 10 minutes for the saturation to go up to 85 to 95%. Discussion on NRP without discussion on meconium is incomplete, isn't it? Meconium is a very close friend of us, particularly whenever there is an emergency term section, we keep in mind that it is likely to be meconium. So how many of us do routine oral suction in a baby who is breathing crying but having meconium stain like that? That is first question we should ask. Second, how many are doing routine tracheal suction even though baby is breathing and crying? Or for that sake, even in the non-vigorous baby also, we are going first as a tracheal section. Then subsequent is how many give routine stomach wash for babies with meconium aspiration. So routine oral suction, then routine tracheal suction in vigorous as well as non-vigorous baby, and doing routine stomach wash. So I think
few
there are
have replied no for all.
So they are not doing routine oral section.
So
They are
no
not doing
for everything.
routine
Yeah.
tracheal section and no stomach wash. So that is very good.
Yeah.
So tracheal sectioning of meconium baby at birth. So this is again evidence from ACOR, which was published in 2019. So the routine sectioning of non-vigorous infants is more likely to result in delaying initiation of the ventilation. So the emphasis is more on initiation of ventilation rather than thinking of intubation and tracheal suction and then going back to ventilation. However, in certain situations where you have tried initial ventilation, but if there is a no good chest rise in that situation where you feel the airways are blocked, in that situation, yes, we need to think of intubation and tracheal suction and then subsequently the positive pressure ventilation. The next is about gastric lavage, particularly for babies who are having a meconium aspiration. So it shows that the gastric lavage is not necessary in most units with meconium stained amniotic fluid, regardless of the thickness of the meconium stained amniotic fluid, as no complications from meconium containing gastric fluid were observed. Now, when you are doing the process of putting a orogastric tube and doing stomach wash and gastric aspirate, there are high chances that baby may omit and aspirate the meconium. So before you aspirate, baby may aspirate. So better we stop this process of doing routine gastric lavage for babies with meconium stained amniotic fluid. So no routine oral suction. Not all non-vigorous babies need intubation for tracheal suction, and no routine stomach wash for meconium aspiration. Now, $1 million question is when to stop resuscitation. There are a lot many rules and laws coming in picture. So in Indian scenario, what we are having evidence as far as our laws are concerned, there was a case in Delhi. So that has erupted a lot of issues about when to stop resuscitation. For a baby whose APGAR score is 0 at 10 minutes, that tells the outcomes are not good. So that is one. Second is babies who are less than 23 weeks, less than 400 grams, and who have also major congenital anomalies. So here I'll be putting a star mark. We need to discuss antenatal counseling is very important. Certain parents, babies who are less than 23 weeks, they want to go ahead with all the possible ways and means. Weight less than 400, still they want to go ahead. So we have to respect the parents' feeling. We need to give the outcome in terms of we need to tell what is the available evidence. But at the same time, with due respect, we need to understand them and then need to give trial. But at the same time, I will say that don't be very vigorous for a baby who is less than 23 weeks and less than 400 grams. So we can do the initial parts, and baby is requiring like adrenaline and all that thing. I will be a bit cautious with this situation. So it is the team efforts which makes a lot of difference Otherwise, we will be landing in a position like this, where one team is doing one job and coming to another end, and we have to do the whole thing again from beginning. So take home message, I have put it into like a take home questions. So what has happened when you join your PG, or what happens when students join to your hospital for training? That is first thing. How many do 3 checks before the birth of baby? How many have got a checklist or NRP algorithm at the resuscitation site? Where do you deliver the baby, on mother's abdomen, or you take the baby on the warmer? When do you climb the cord? Thermoregulation, what are the precautions you are doing? How do you give positive pressure ventilation? When and how are you giving oxygen? And meconium stain, don't do routine tracheal or oral section, and don't do stomach wash. So we missed this part of the discussion. However, Dr. Jitendra has already said that they have arranged food in their own home so they can have their dinner now. However, at the same time, if there are any further doubts or questions or comments, we are welcome for that. And this is not the end. Let's begin with the change. So I think we can have the questions before, and then I want to share with you another video, which is like a summary of what we have discussed today. So by the time I'm arranging for the video, we can have the questions if there are any, or comments for that sake, please.
So we are open for any questions from the participants. Okay, if I can ask a few, or rather just point out the difference between term and preterm NRP is mainly thermoregulation, which comes right on top for preterm NRP. Am I right,
Very,
Dr. Omprakash?
yes, that is most important thing.
Okay.
So it is TABC. Normally we say ABCD. No? So for preterm babies, it is a temperature, airways, breathing, and circulations.
Perfect. And what about umbilical lines and NRP? Are there umbilical lines in the guidelines,
Yes.
and where
So
do they come?
umbilical lines play in 1% situation, as I said, where we need medications. In that situations, we need to think of umbilical lines. And the best way of giving medication is having umbilical access. So I will say it is beauty of the nature that we have got a easily accessible umbilical veins through which we can put the catheter and give adrenaline, and which we know that it is the effective way of giving rather than giving the tracheal adrenaline.
Or intraosseous as well is as good as umbilical venous access.
So in a situation where we don't have an umbilical access, intraosseous will be a better option instead of tracheal, because tracheal absorption we are not very sure. As we say, like we use almost like a double the dose than the normal. So we'll prefer intraosseous instead of the tracheal way of using adrenaline.
Okay, so the drugs used in NRP, the past and what has changed from before to now?
So naloxone, I have not gone into all the details, but naloxone is again not suggested, because in Indian scenario, fortunately, we don't have mothers on opioids and all that things. We rarely face that kind of situation. So again, there is more focus on the management of the airways rather than giving naloxone.
Okay, and so apart from naloxone, so it's adrenaline, normal saline as a volume expander, or
Yes.
rhesus negative blood. That's the only thing. And what about NRP in a known case of diaphragmatic hernia?
So we should prefer to do elective intubation instead of diaphragmatic hernia. If we know anti-acally diagnosed diaphragmatic hernia, so we should. These are like a special situations or special scenarios. Diaphragmatic hernia is there, pneumothorax is there. We need to put a small needle and then do the immediate relaxation of the pneumothorax.
Okay, so if I can just share a question, Dr. Parth Desai has shared that he does prophylactic gastric lavage in term babies to reduce the intolerance, gastric intolerance, or what we call as Liker
Yes,
gastritis. So is that the right practice, or would you not?
So I have shared this evidence already. So in that study also, like only 13% babies have got this issue with the meconium gastritis. Okay. And as I told you, the risk of aspiration during the process of doing this is high rather than benefit of procedure.
So apart from meconium, even in normal vigorous babies, you suggest not to do a gastric lavage.
No. See, so gastric secretions are very important barriers. So in fact, I always suggest like don't use antacids in the babies because many people they have got low threshold for starting antacids. So antacid has got a direct correlation with development of NEC and fungal infections also. So we need to be very careful when we are giving the gastric lavage or giving the antacids for the babies.
Perfect. And Dr. Priyanka asks about ratio of compression to breaths during NRP.
So here comes the coordination. When we are doing only positive pressure ventilation and you are doing positive pressure ventilation with chest compression. So now when you are doing positive pressure ventilation, there is a sequence, breathe 2, 3. And in the same sequence we need to do so that we make sure that we are giving at least 40 to 60 breaths in 1 minute. So this has to be done by practice again and again. In case of chest compression, there is a need of 2 persons. So one person doing the chest compression and one person doing bag and tube ventilation. I will say tube ventilation because before we go for chest compression, we make sure that ET tube is in place that gives effective positive pressure ventilation. So there is again a sequence for that. So breathe 2, 3. That is for just positive pressure ventilation. However, for the chest compression, so there are 3 compressions and 1 breathe. So in this way, we are at least trying to reach to rates of almost like 90 and 30 in 1 minute kind of thing. So 1 and 2 and 3 and squeeze. So here 1, 2 and 3 are chest compressions and then squeeze is the bagging of the baby. And when you are doing chest compression, the 2-finger technique, that is one, and the thumb technique. So thumb technique is preferred more in new NRP than 2-finger technique because that gives a good support to the chest of the baby as well as that helps us to make sure that you are doing effective 1/3 compression of the chest. Okay, so that sequence, and I will say again and again that you have to practice it. The sequence of only positive pressure ventilation and coordination of positive pressure ventilation and chest compression.
Perfectly explained. Any other questions before we go on to the video?
No, actually, there are few on video, YouTube also. Dr. Don from Dubai is asking why we are not going away with the APGAR score totally.
So APGAR score during resuscitation we are not using. We are using as one of the ways of assessment in terms of predicting about the morbidities, mortalities, and in fact for the therapeutic hypothermia also, that also one of the criteria what was used in TOBI trial, that is also one of the criteria. So that is not for the purpose of NRP, that is more for the later outcomes and morbidities.
So if I may clear this point, is APGAR score needed legally for every delivery?
So some parents very specifically ask, what was the APGAR score of the baby? So it is good to document APGAR score. That is one thing I will say. Second is, once you start resuscitation, one of the ways of proper documentation of thing is again, one person who is dedicated for the documentation, he should document the time frame, at what time, what actions have happened. So that will indirectly help us at the end of 1 minute, what is the situation of the baby in terms of the breathing, the parameters that we look in the APGAR score, Okay. But again and again, I will enforce like APGAR score is not the way to think of assessment during resuscitation, particularly when we are in the first golden minute.
I think Dr. Pradeep Reddy has a question. Is there any role of sodium bicarbonate during
very important? So soda bicarb has been brought out. First and foremost thing, what we are giving soda mask is metabolic acidosis. So here, until and unless proven, it is the airway which is compromising the baby. So first thing is establishing effective positive pressure ventilation either by bag and tube ventilation or bag and mask ventilation. And bicarb has to be given in a situation where you feel a documented metabolic acidosis is there, and in that situation also not immediately. We need to give some time for the baby for adaptation. Particularly in a preterm baby, I will say a big no for soda bicarb. in a term baby, particularly baby with meconium aspiration, PPH, in certain situations we have used bicarb, but again not immediately after birth. We give some time for them to get adapted. We use first the fluid boluses because perfusion is another factor which will improve the metabolic acidosis also. So once the perfusion is improved by giving the fluid boluses, and if there is a need of inotrope, that also will add on. If in spite of all this, and when your ventilation is established, in that situation, if still pH is less than 7.2 within first 24 hours of life, we can think of giving bicarb, but not during the time of resuscitation.
Perfect. Dr. Jitendra, any questions
Yes,
on
sir.
your side?
Only sir wants to ask one question. Sometimes we come across a scenario where gynecologists are taking for abortion or spontaneous abortions, and they don't give us call out. Then what they observe is baby is breathing, but whatever is the reason for abortion, spontaneous or whatever. So, what is the latest definition of viability? And when should be the masterly inactivity from our side?
So less than 23 weeks, less than 400 grams. So that is one which is very clearly documented. Second, as I said, communication with the parents. That plays very vital role. We have been in the same situation, in fact, with sir, that we have to observe the baby in NSU because the heartbeat is there. You know? So we can't declare in this situation, and sometimes these babies take longer time for the heart to disappear even without doing any even the masterly inactive. So we have to antenatal counseling. That is one if time permits. If not, then we need to explain at the time of birth of the baby that this is the situation. Baby is less than 23 weeks, less than 400 grams. We couldn't manage to give any steroids, so likely possibility of survival are less. So take their views, respect their views, and then accordingly you decide what is best by in the interest of the baby and in the interest of the parents.
They are okay with DNR, but we should take the baby to NICU and do whatever we can. You mean?
Yes. So if the babies, see, we can observe for certain time frame, like based on the hospital policies, if they do allow us to observe in the delivery room itself, that is best. However, in a situation, if it is not permittable, not allowed, then we may have to take the baby in the NICU where we can just be masterly inactive and observe the baby.
So, are there any legal implications of that?
So legal implications are there, but whenever legal implications are there are certain guidelines are there which are going to help us. So see, all these people, they look at evidence, they look at the guidelines, and it is not, and that is the reason the NRP gives guidelines, regularly updated guidelines based on the evidence. So if you follow these guidelines available, and if the guidelines are saying like less than 23 weeks, less than 400, it is documented, is there. So that should not cause problems to you. But there will be one-off cases where all things will come in forward, and again over a period of time it will disappear.
There's one question from Dr. Park Desai. Role of magnesium sulfate in asphyxiated neonates for potential risk of HIE.
So magnesium sulfate is not a part of resuscitation. We are going to be very confirm with the medications required at the time of resuscitation. One is the epinephrine, saline, and in a situation where there is a blood loss, ORH negative blood. These are the only things which are required as far as medication is concerned. Magnesium sulfate, bicarb, and all that things comes as a second phase. But yes, there is a role of magnesium sulfate in case of asphyxia, in case of pulmonary hypertension in both situations.
Okay, any more questions, Dr. Jitendra?
Nothing on you.
Yeah, I guess we are done here as well.
So I think, as I said, that is not the end. So let's think of having some change in what we are doing in our practices. So I'll just try to share this video and then let's see. So this video is basically about the human factor. We need to take into consideration the person who is working with us, the person who is around us, maybe the parents of the baby, maybe the baby or the other patients in the vicinity, and then accordingly we need to respond to them. So is the screen visible?
Yeah.
Yeah. So I'll start the video. So in addition to video, there is a visual thing is also there, so you can read it simultaneously. So we need to understand where we are working. We need to understand the person, what their situation is before we comment or communicate with them. So that is very important. And then that will give a wholesome or a holistic approach to the problems that everyone is facing.
I think you did it brilliantly,
last
Dr.
May.
Omprakash.
Last में सेंटी बना दिया.
I know everybody were like taking the moment to come back to the real world. But it's true, isn't it?
But
Hospital is
yeah,
like
actually,
a
compassionate care is very important.
Yeah.
Yes.
I request Dr. Mangai to offer official vote of thanks.
Thank you, sir. Thank you, Dr. Omprakash Jamadar, for such a wonderful interactive session to handle the golden minute of the newborn. His style of using videos to emphasize the points, and even the last video where the message directly reaches the heart, it's really nice. I like the way you went through each video and then you had an interactive session after that and emphasized and how you related that with your talk. Thank you, Dr. Shantala, for moderating this session in the calm and composed style, which is your unique identification. Thank you, Dr. Jitendra, sir, for giving us such learning sessions even during the lockdown. Thank you, Dr. Vikram and Dr. Satish Sahane, for being the backbone of all the online CMEs and doing all the background work so that all of this runs smoothly. I also thank all the students, the PG students who were there, who were actively messaging on the chat box and interacting. Thank you for being alert throughout the session and interacting. Thank you for the delegates who have joined us on Zoom and on the YouTube channel. Thank you.
Mangai, I had promised a gift to the one who responds the most. So I think that goes to Dr. Jitendra sir to give whatever.
All the residents were feeling an invisible hammer on their head when I was around.
That's always the case. The residents must be relieved it's over. That's their gift.
Thank you, Omprakash, for a wonderful talk. And thanks all the delegates.
I must thank Dr. Jitendra, Dr. Satish, and Dr. Mangai as well as Dr. Vikram. They are coordinating since such a good long time, in spite of their having other busy schedule activities. And it is a team effort. I always say Navi Mumbai is like a family affair. I started with that itself, So we enjoy a lot. Somehow we couldn't be with my busy schedule. I couldn't be, but thank you for giving me opportunity to share these thoughts, and then hope the change begins rather than just end of the session. Thank you very much.
Thank you.
And at this point, I just want a formal official consent for uploading this video on the YouTube.
Yes, please. Yes, please. Yeah.
Thank you.
Thank you. Pleasure. Yeah.
Thank you.
Thank you. Good night.
Thank you all. Thanks a lot.
Thank you, Dr. Vikram. Yeah.
Good night.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.
We are the NRP.
We heal with zeal.
Together we navigate
New frontiers.